I was given the topic, this is really the only incontinence talk today, so I'm going to try to be as broad with it as I can. And the question is sacral neuromodulation still the best treatment? I think I could just put the next slide up that would just say yes, and we could be done, but hopefully I can try to explain why. And it's a little bit about that and a little bit about the lack of other options that makes me say that. No financial disclosures. I was an investigator on a trial that I'm going to talk about. And I'm going to try to talk a little bit about why I think this is a good treatment, why I think some of the other treatments haven't worked quite so well, and a little bit how you can incorporate this into a strategy, assuming that you've tried all of the conservative things that you would try with these patients beforehand. The basis of this is not a new technique. It's not a new procedure. This is an example here. You can see the x-ray of a lead placed. This is me actually in the office. Patient is awake. You can actually do the test in the office, and I think that's the greatest thing about this procedure is that you can actually test and try the therapy. You can't try a ventral rectopexy and see if it works. You can try sacral neuromodulation and see if it works, and I've gotten to the point it probably takes me about 2 to 5 minutes to put 2 leads in the office, and the patient goes home, and you get to see if the treatment works for them. So it's a great benefit of the technology. We have lots of data that it does work. These are all mostly multi-center trials. This was the 5-year data presented several years ago by Tracy Hull, and you see if a red bar is good, that means that you got at least 50% better. And if you follow longitudinally over time, almost everybody gets at least 50% better if you go through this process and pass a test. And you see some of the blue bars on there showing that there's actually a substantial proportion of patients that get 100% better, which is not something that we see with a lot of the other treatments. And then I feel like you guys invited me here to tell you about all the things that have just failed and not worked. I spent my morning talking to you about other things that don't work, but we have a lot of failures in this realm as well. And some of these sounded like a good idea at the time and just didn't pan out. Unfortunately, we had something like the mesh sling. Dr. Melgren, when he was here, was part of that trial. The results were decent, actually worked well, but the legal environment is such that pelvic mesh is a no-no and it's off the market. I'll talk in a minute about injectables and tibial nerve specifically as to why those didn't work. The bulking implantable agents just didn't work at all. And the one that sort of made me a little bit frustrated was the magnetic sphincter, which actually did work and was useful and had a whole lot less complications than the old artificial bowel sphincter. And for business reasons, the product was basically taken off the market by the company that bought it. So that one stung a little bit because I think we have a gap, and that was potentially going to fill part of that. Looking at some of the other agents, so particularly the bulking agents, this thing, I could put up a slide here. We had the Celesta product in the United States years ago that was quite heavily marketed, but I could put up a slide showing about 25 to 30 different compounds that people have tried to inject over the years that have just failed. Some of the long-term follow-up studies show that if you actually follow these people over time, years down the road, their incontinence scores go back to baseline. And if you actually do ultrasound, you can prove that the bulking agent actually moved or completely disappeared. So it makes sense that their symptoms go back to baseline over time. And so I think this is why that's not a great option for this. Tibial nerve stimulation seems interesting. Can you just stimulate the tibial nerve and send the impulse back up? This is something we do for overactive bladder, but not FI yet. Many years ago, my group was involved in an industry-sponsored trial. We were doing this. It's simple enough. It was working well, but at the same time, there was this multi-center trial that was going on in Europe, and the results of that trial were so bad that actually the industry-sponsored trial got shut down, and we just stopped. And if you look here, marginally, if at all, better than sham, and the conclusion from the paper would be it would be difficult to recommend this therapy for patients in the population studied, and I think I would agree with that with our understanding today. I talked about how the artificial bowel sphincter was not a good option. Radiofrequency didn't seem to work. The dynamic gracilloplasty is not only not available in the U.S., but it is quite an extreme option. The Malone procedure is more of a pediatric thing, so there really isn't much else out there. I'll talk to you about a few options that are. Here's one. This is a vaginal bowel control device. I put this up there because it has at least been studied and it's at least available. The concept goes like this. You have a implantable, removable device that the patient would insert on their own into the vagina. A balloon gets inflated, and it is supposed to keep stool from leaking out of the rectum. It had at least one clinical trial. This was a multi-center study that we were one of the sites that participated in this. Limited number of patients, and it showed reasonable success over time if you could be fit. Many people, the device just didn't fit, it wasn't comfortable, and it wasn't a good idea. And on the surface, it looks good. You see fecal incontinence episodes going way down over time, and that at least looks good. You see quality of life scores going up, and that also looks good. But then when you really look into this a little bit closer, if we're talking about a St. Mark's score of about 16 at baseline and getting down to 10 after the treatment, the St. Mark's score of 10 is not very good, and actually there's some literature out there that when you get to a Cleveland Clinic score or a St. Mark's score of about 10, you're bothered enough that you're going to seek treatment for that problem. So I think probably it's available, I mentioned it, but probably not going to be the solution. Sphincterplasty is probably the other thing to consider, and I think it still is a good solution if you use it right and if you use it in the right patients. This is an old study. Ann Lowry did this study many years ago in DCNR and just looked at the outcomes over time, and it's just worth looking at saying that the outcomes are going to be reasonable, or at least in this study quantified as good in the majority of patients up front, but that they will decrease over time. And I think the reason they will decrease over time is there's more components. There's a lot more to this than just a muscle injury, and we need to understand that. And the way I take a step back from this disease process and look at it, I think it's really a connection between the brain and the spinal reflexes and the muscles, and all of this interplaying together is what's going to give a patient reasonable continence. Some of the SNS studies certainly show that. This is a study showing where the processing is in the brain during a test stimulation versus chronic stimulation, so seeing some changes in the brain over time with this therapy, indicating that this is more than just a muscle function. Going on that theme of muscle function, when you actually do tests, you do manometry tests and you test muscle function, it doesn't change. So the manometry values stay the same whether you have a stimulator turned on or off. It's more than a muscle function. I think it's more of a neuromuscular coordination. And going with that fact, then you take a look at that and you say, okay, if a patient has a sphincter defect, does it really matter? So there's a red line and a blue line. Essentially, you have patients who had a sphincter tear versus those who didn't. They're treated with sacral neuromodulation, and they got the same results. So I think this story is more complex than just thinking about the muscle alone. What about whether they've had a prior repair? So if a patient comes in and gets an initial good result with a sphincter repair, and then the results get bad over time, you can still treat with this technology and they receive the same improvement. And when we talk about what type of testing we need to do for this, whether they have a pudendal nerve value that's normal or abnormal on the test, they still have success with this. This was echoed. This was some of our own data. This is many years old now, but we had about 150 patients in the series. Sphincter defect, no sphincter defect, it didn't matter. They all actually did quite well with this therapy. One comparative study, sphincter repair versus SNS, slightly different patient populations. Suffice to say they both did reasonably well, but the study was very small. But when we talk about the upside, I talk about the good things about it. There are some downsides, which I hope will be mitigated by some of the future generations of the products that are available. So I'm going to talk a little bit about the future. Right now, this is the sobering reality of this. If you take care of these patients, you have to take care of them for life because they will come back. The battery will die. The lead will need to be removed because somebody needs an MRI. You need revisions and replacements over time, and I think with some of the new technology, a lot of this is going to decrease. Last point on that is that we really need follow-up over time. The whole reason I put this slide up is to show that you have to follow them and be engaged with the care. This was something I was part of with the International Continence Society. We made some troubleshooting guidelines, more of a reference to keep in the back of your office, but suffice to say there are a lot of situations that come up that you need to be able to handle and troubleshoot if you're going to take care of these patients. More exciting, though, talking a little bit about the future, and I think that the devices that are available are going to start changing, and hopefully changing for the better. MRI safety will now be the new norm, both with the currently available product, which is in FDA approval right now to have an MRI-safe product out by the beginning of next year, hopefully, and with another competitor that has just hit the market. But the next generation of these that will be available very soon are actually MRI safe, and now will potentially have some options to be rechargeable. So think about the old device that was the size of a book of matches. This will be a thumb drive or smaller, And I think that will eliminate some of those revisions that we see over time. Now there's a little bit of competition in the market. I decided not to put any data up, but suffice to say there is a new company that has come to market, is FDA approved with a device for sacral nerve stimulation. There is one published study. For those that are interested, it was just published in the last month or two in the journal called Urology. The reason I don't put it up here, it's not very clean data. Essentially what they did was studied patients with overactive bladder, went back into the study and found that some of those patients had fecal incontinence too, and they reported that those patients did improve. The results were reasonably good, but I'd like to see a clean study with patients that just have fecal incontinence. So I'm all for competition if we have some data that can compare one to the other, and I think that because of the new changes in the devices, there will be a lot to be determined in the future. To just be more complete about it, I show you all these good slides about how it works great. I think you can try it in anybody that you'd like, and the results are not always going to be perfect. So this was a study that showed a little bit less long-term success. When you dug a little bit deeper into this study, they essentially tried this for anybody who failed medical management for fecal incontinence. And it worked in some of these people, but if you look at some of the specific situations, somebody who has low anterior syndrome, people with the, dare I say, stapled hemorrhoid operation in front of Dr. Goldberg, but people that have had anorectal surgery. So it's worth trying in some of those groups, but you have to expect a little bit less perfect outcomes. Change gears to the last part. I hope that if any of you were taking a board exam or something and you saw the patient that had this and they're incontinent, I hope you would fix the rectal prolapse and see what happens to the incontinence and then deal with the incontinence afterwards. But what would you do? We just talked a little bit in the last couple of talks about the patient that has constipation and a high-grade internal intussusception. What do you do with the patient that has fecal incontinence and the high-grade internal intussusception? Because this is where it gets a little bit more interesting. Particularly the group from Oxford has written a series of papers on this that at least got me thinking about it. So this is a group with Ian Lindsay, Oliver Jones. If you look at their data carefully, if a patient had a high-grade internal prolapse, the test success was much lower with a sacral nerve stimulation test. They put that test lead in and test them, and those patients didn't do so well. They followed that up with another paper showing that actually outcomes with a laparoscopic ventral rectopexy improved fecal incontinence scores. And then they followed it up with another study suggesting that we flip the algorithm backwards and basically fix the internal prolapse first and then do sacral nerve stimulation if it doesn't work, and that could still work. I'm not sure that I'm quite there yet on all this, but it has my attention. I think that we don't need to necessarily screen for this, in my opinion, in every patient that walks in. I think if you dig a little bit deeply and take some questionnaires, a lot of these people have a mixed constipation and incontinence phenotype, and you can dig that out on a history and see if you need to do any of this. But this at least has my attention to say that it might not just be a one-size-fits-all type of algorithm. In conclusion, many treatments have failed. Sphincterplasty, I think, is a great operation, certainly a fun operation to do. It is an operation that gives some quality of life once they've healed for particularly the younger patients. But sacral nerve stimulation is effective and continues to be so. It doesn't work for everyone, but it's got that test phase that we can rely on. I think we've got to follow the patients up long-term because of the troubleshooting that I talked about. And I'm very interested where this internal prolapse subject is going to go in the future. I think that needs some further study. Thank you for your time.